Hi, everyone. My name is Deepa Halaharvi. I'm a breast surgical oncologist with Ohio Health, also Associate Program Director for the Breast Surgery Fellowship. I mainly wanted to create this PowerPoint as an introduction to you, general surgery residents, before you come to our service. It is really difficult to stop in the middle of seeing patients to talk about some of these concepts. So I wanted to make sure, put it all in form of a PowerPoint and make a YouTube, and then you can watch it before you come to the rotation. There's going to be a second video that talks mainly about dense breast tissue and mammograms. And Dr. Kripe and I made that for more for the FP residents, OBGYN, but I think you really will also find it beneficial. I will give the links to both this PowerPoint video as well as the other one. So you have time to prepare before you come on the service. So when you're on the service, we can just focus on taking care of patients and then operating in the OR. So, all right, let's get started. So the main objectives are reviewing breast anatomy, lymphatic pathways, evaluating common benign and malignant breast presentations, choosing the diagnostic and therapeutic steps. I actually took a step further and incorporated some score questions. One of the residents was kind enough to give me some of the score questions. So I have incorporated that into this PowerPoint and the video, and hopefully that will help you. And then understanding the principles of breast reconstruction. Let's get started with gross anatomy. So, breast is between subdermal fat and superficial pectoral fascia, and it's right here. This is the chest wall. So, breast has its own fascia, and then there is the superficial pectoral fascia, as well as retromammary fascia that's right behind the breast tissue. The breast is usually lobes that becomes lobules, then TDLUs, terminal duct lobular units, right here. Cooper's ligaments are these guys right here. They tether the skin. This is what causes the dimpling with cancer. Cooper's ligaments, that may be a question. And like we talked about, retromammary fat right here is the fat pad over the pectoralis muscle. And that's your surgical plane that you want to be in when you're operating. Axillary levels and nerves. Lateral to level 1 is considered, lateral to pec minor is considered level 1. Behind the pec minor is level 2, which is also called the Rodder's nodes. The lymph nodes are called Rodder's nodes. And medial to pec minor is called level 3, and that's the subclavicular nodes. And this is important during axillary lymph node dissection. You want to make sure you're preserving the long thoracic nerve, thoracodorsal, medial pectoral, and intercostobrachial nerves if possible. The question that you get asked on ABSITE and on SCORE is what happens if there's injury to long thoracic, and that's the wing scapula. If there's injury to intercostobrachiocutaneous nerve, you can have medial numb arm in the medial side. Lymphatic drainage. 75% of the lymphatic fluid goes into the axilla. Remainder goes to the internal mammary and then supraclavicular lymph nodes. There's what's called Sapes plexus that is right behind the areola. It's called Sapes subareolar plexus. That's where we inject the blue dye and the radioactive tracer that follows these lymphatic channels into the lymph nodes. And regardless of where the tumor is, there has not shown been any difference in the flow of the blue dye and the radioactive tracer into the axilla, whether you inject behind the nipple where there's very big amount of Sapes plexus or right next to the tumor. So TDLU, terminal ductal lobular unit, right here. That's the site for non-invasive cancer, as well as invasive cancer. DCIS, LCIS. LCIS is not cancer, it's just high-risk lesion. If the myoepithelial cells and there is intact basement, it's called in situ. So if the cancer has not gone outside the cells, outside the basement membrane, it's in situ. That's the DCIS or the LCIS. And again, LCIS is high-risk lesion. It used to be called cancer in the past. If the cells invade the basement membrane, then it's invasive cancer. And that's usually how it can spread to the lymphatics, into the lymph nodes, so on and so forth. So fibrocystic change and mastalgia, it's common between ages 30 to 50. Cyclical mastalgia usually comes every month right before periods. It gets better after periods. On imaging, usually there is diffuse density cysts and usually not palpable. And you can also have atypia, atypical ductal hyperplasia, which does increase the risk of cancer, relative risk by fivefold. But fibrocystic change alone is just normal breast. There's no increased risk with that. So question to know for the score is breast pain alone without mass or imaging abnormality is very rarely cancer. A lot of patients come in because, they now have breast pain. Only 5% of the breast pain has breast cancer. By the way, all of this comes from your Sabiston chapter, so nothing I'm making up. So if you have any questions, you can always go back and look it up on Sabiston. Let's look at simple versus complex cysts. Simple is cyst where there is anechoic thin wall, and you aspirate it only if it's symptomatic. Otherwise, there's no risk for cancer. The complex cyst, however, on the other hand, it has the thick wall, septations, solid components, and that biopsy is indicated, especially depending on the size of the complex cyst. So again, a score question. I saw a 32-year-old painful 3-centimeter complex cyst with septations. This person needs a biopsy with a clip. And this is just aspiration is not enough because there are solid components. You do worry about malignancy. Fibroadenoma is most commonly seen in young women. It's mobile, rubbery, well-circumscribed mass, often multiple bilateral and in bilateral breast. Sometimes the biopsy is shown to be fibroepithelial lesion. That usually means we don't know if this is a fibroadenoma or a phyllodes tumor, so they really need to go to surgery to remove that. And the question that may be asked on score is fibroadenoma, commonly associated with multiple breast masses. It's smooth, mobile. I think the teaching point is you really need to get a biopsy to make sure it's not cancer, but most of the time that's fibroadenoma. And these are usually most commonly in young women who are on birth control, and getting a biopsy is a good idea. Nipple discharge, benign versus pathologic. Physiologic, which is benign. Usually nipple discharge is coming from both breasts, multiple ducts, non-bloody, and only with expression. If it's pathologic, meaning worrisome, then it's unilateral, single duct, spontaneous. It could be serous or bloody or clear. Most common cause of unilateral bloody nipple discharge is solitary intraductal papilloma. This is a common question you'll get asked. And it could be something like a 65-year-old with unilateral bloody nipple discharge, most likely causes intraductal papilloma. In lactating women, galactoceles are most commonly seen, and usually they present as complex cystic lesion. They get a biopsy, it's found to be galactocele. There can be milk drainage from the biopsy site, but it's okay. You really want to continue breastfeeding. The whole thing about milk fistula was a big thing when I was a fellow. We talked a lot about it. Don't biopsy these pregnant women anymore. That is sort of debunked. It's okay to get a biopsy. The milk fistulas typically close, and you want to continue breastfeeding and continue any local care. Rheumatoid mastitis, often seen in reproductive age women. It's first you want to rule out infection like TB or fungal infections before you start them on steroids. And they're usually present with this really firm, painful mass. Sometimes they get called inflammatory breast cancer, but usually they'll have fevers, chills. There's a palpable mass. It's very much like a mastitis, but it's typically seen in Asians, Hispanics, African American women. And unfortunately, this is a big problem. I have a lot of patients who have this condition. You don't want to remove it going to surgery. You do want to treat them with antibiotics, steroids, and anti-inflammatories. But you don't want to take them to surgery to excise this. And it's always important to rule out TB. And this is a tough condition to treat. Patients are usually very unhappy, obviously, for good reason. So let's talk a little bit about atypia and LCIS. So I think when I did the lecture for you guys with the AppSite review, I go have all the picture of the duct of the breast with the nice round cells inside the duct is normal duct. The cells start dividing, multiplying, and if they're atypical and they're less than half the duct, it's ADH. If it's more than half the duct, it's DCIS. Same kind of thing in a lobule, atypical cells less than half the lobule is called LCIS. The reason I want to talk about is they're considered risk lesions. They are fortified relative risk. This is very different than absolute risk. Relative risk is someone you're comparing to other population. So my relative risk 5%, 5 times compared to the population, to the normal population. But absolute risk is very different. That's only 0.5 to 1% per year. LCIS, it is a bilateral risk factor, meaning bilateral breast cancer risk factor, 1% per year. We typically say about 9 to 10% fold risk of developing cancer, not percent fold relative risk, or 1% per year. And when you excise these, you don't have to get negative margins. And also, it's a controversial topic, both the ADH, ALH, and LCIS, when you would excise them, when you would not. If the imaging is suspicious, you want to excise them. If it's discordant, you want to excise it. Most of the time, we do excise them because we want to know that there's no cancer. There is no upstaging to cancer when we go to surgery. And also, it gives us an opportunity to talk about risk reduction, not only with imaging, but also with anti-estrogen medication. I guess the question seen on score is at the excision with ALH, ADH, or LCIS. If it's on margin, you don't need additional surgery. They do need surveillance and risk reduction. Let's talk about risk factors for breast cancer. Dr. Kripe will ask you these questions when you come on board. There's non-modifiable risk factors, modifiable. The non-modifiable risk factors are something we cannot change, your age, your sex, early periods, late menopause, family history, prior chest wall radiation, personal history of LCIS or ADH. Modifiable risk factors are like obesity, alcohol, HRT, physical inactivity, so on and so forth. So for a score question, they will ask mantle radiation for Hodgkin's lymphoma. That is supposedly the highest relative risk among the several listed factors. This table is from Sabiston, so make sure you look at it. It is pretty inclusive and is pretty good. And I don't want to read it for the sake of time. Hereditary breast cancer. We mostly talk about BRCA 1 and 2, BRCA. BRC, they're both around 70-ish% risk of developing breast cancer, about 40% risk of developing ovarian cancer, and often triple negative breast cancers. BRCA2, not just breast, but also ovarian, prostate, and pancreas, but also risk of male breast cancer. BRCA carriers, they need MRI screening as well as mammograms. I like to alternate it. You don't have to alternate it. MRI, or you could get them at the same time. But for me, it makes sense to alternate it every 6 months for them to have imaging. So MRI alternating with the mammogram. You can talk about risk-reducing mastectomy. There's no survival benefit, but there is a paper that just came out talking about, it's a meta-analysis, no, not a randomized control study. So I did talk a little bit about benefit and survival with a mastectomy. It's something new. We always told patients that there's no benefit. It does reduce the risk of developing breast cancer in the future by 90 to 95%, depending on the age of the patient and whether they're premenopausal or postmenopausal. There's also risk reducing bilateral salpingo-oophorectomy. That, I believe, does decrease the risk of decreased mortality. The question and score, women with multiple relatives, including father with breast cancer. The best person to test is the father with the breast cancer. And if he's positive, then test the patient, the daughter, whoever presented. The teaching point is you always want to test people that are affected first, affected family member. So let's briefly talk about imaging, mammogram, ultrasound, and stereotactic biopsies. So mammogram is screening versus diagnostic. Screening is just when patients don't have any symptoms. Starting at age 40, average risk women need to get a screening mammogram once a year, every year, as long as they're alive and in good health. Diagnostic mammogram is when they have symptoms, pain, mass, nipple discharge, things like that, or finding a mass, whether the patient finds it or the doctor finds it. They usually have magnification, spot compression views. Ultrasound is first in young women for cysts or solid lesions that they present with. MRI typically is reserved for high-risk lesions, high-risk screening to rule out extent of disease if they have breast cancer, if they have implants, if they have BRCA mutation, if they have occult lesions. Those are all general guidelines. NCCN has a good list for who needs an MRI. And we typically get a stereotactic biopsy for calcifications or architectural distortion seen on imaging on a mammogram. And also, I wanted to say that you can, I did not go too much into detail about that because there is this other video and PowerPoint that Dr. Kripe and I gave to FP residents and OBGYN residents, which talks a lot about screenings and also dense breast tissue and in how you image them, because there's a whole new algorithm for how what type of imaging to get and things like that. This I kind of want to keep strictly for the surgical residents. So let's talk about BI-RADS. 0 is incomplete, additional imaging is needed. BI-RADS 1 to 2 is negative, benign, routine screening yearly. BI-RADS 3 is less than 2% risk of developing cancer or less than 2% chance of finding cancer, so they can just be followed in 6 months. If it's BI-RADS 4, there is A, B, and C. A being 2 to like 50% risk of developing cancer. 4A, 4B is like 50 to 75, and then 4C is 75 to 95 risk of not developing cancer and finding cancer at the time of biopsy, core biopsy. Risk of finding cancer with BI-RADS 5 is 95%, and BI-RADS 6 is known malignancy. So breast cancer is the most common cancer, also second leading cause of death after lung cancer. 5-year survival is somewhere around 93, 95%. If you catch it early stage, good prognosis, good survival. That's why we push mammograms. The breast cancer risk does increase with age, and of course, most of the cases are postmenopausal. Screening, we recommend annual screening mammography at age 40 and repeat a mammogram once a year. And then for boards, make sure you know when the appropriate screening is, when the high-risk surveillance are needed for the high-risk patients. We'll go through that here in just a minute. But mammograms decrease the mortality by up to 30%. So who is average risk versus high risk? So average risk is someone that does not have family history of breast cancer. They have not had high-risk lesions. They don't have mutations. They have not had radiation. If you calculate their risk by accepted models, their risk is less than 20%, typically less than 15%. The 15 to 20% we consider intermediate risk. For high risk, usually anyone over 20% lifetime risk of developing cancer, typically if they have a mutation or they have family history, they have atypical such as ADH, LCIS, or they have had prior chest wall radiation. And how do you screen these patients? Well, average risk, you just want to see them starting at age 25 to show them how to do a breast exam. Every 3 years or so, you want to see them up to age 40. Starting at age 40, they need a yearly mammogram every year, once a year, until the life expectancy is, that should say less than 10 years, not greater than 10 years. And the modalities, you could do 2D or 3D mammography. And for exams, safe answer for asymptomatic average women is to get a mammogram every year after age 40. High-risk people, so who are the high-risk people? Again, based on Tyrer-Cuzick, BRCA-PRO, GALE, all risk smaller calculations, the risk is over 20%. Or if they have pathogenic mutations, or have had radiation to the chest wall. So they really need an MRI in addition to a mammogram. And breast exams is going to be every 6 to 12 months, starting at age 25, or whenever their high-risk status is recognized. They typically need a mammogram 10 years younger than the youngest affected relative, but not before 25. Breast MRI with contrast, that usually starts at 25, but mammogram does not start till age 30. So you can't start mammogram before 30, and MRI doesn't start before 25, and it's done yearly. And after 30, then you can alternate mammogram and MRI. And how do you know the high-risk calculators? And I'll go through that. There's Tyrer-Cuzick, GALE are the two common ones that we use. NCCN considers high risk. We went through this already before. Prior chest wall radiation, LCIS, ADH. If someone has had LCIS, ADH, they're not automatically high risk. You need to calculate the risk. And if they fall into the more than 20% high risk, then along with the clinical breast exam and mammograms, they need an MRI. And yeah, like I said, the teaching point, just having ATPI is not enough. All of everything else needs to fall into place, and the calculation needs to be over 20% to call them high risk. You can't just call them high risk just with ADH or LCIS. So when do you stop screening? Usually after 75 or 80, as long as they're life expectancy is less than 10 years, and meaning they're going to do something about this cancer. For very frail elderly, the harms of continued screening may outweigh the benefits, and that's the whole point of that. So, talking about the risk models, decide who qualifies for MRIs, chemoprevention, genetic counseling. So, there are a couple of risk models we'll go through. Gale risk. Gale risk looks at age, age at menarche, age at first live birth, number of prior biopsies, presence of atypia, number of first degree relatives. It's widely used for chemoprevention as long as more than 1.7% 5-year risk from Gale. It underestimates risk in strong family history, does not incorporate detailed family history of ovarian cancer. So that's the downfall of Gale. So Gale is only good if you don't have strong family history, if you have personal history of atypia, or if you have a first degree relative, mother, sister, daughter with atypia or cancer. It's mostly cancer, not atypia. But if you have atypia or your first degree relative has cancer, then you can use Gale. Otherwise, you need to go to Tyrer-Cuzick. So this one puts in first, second degree relatives and all the other things you see in there. You plug these numbers, then you calculate the risk. If it's more than 20%, then they're considered high risk. There's other models we typically don't use. The genetic counselors uses BRCA Pro and Klaus. I'm not sure if you'll be tested on this. But again, how do you use it or when do you use it? So breast cancer risk assessment usually starts at age 25. So, and these are the patients you take their family history, personal history, and menarche, impurity data, biopsies, and all that stuff. And then you plug in all the numbers. You don't need to memorize anything. There are models that you can just Google and find these risk calculators. So an example, a 38-year-old woman with a mother with breast cancer at 42, maternal aunt with ovarian cancer at 50. You can use Tyrer-Cuzick. So their risk, if it's over than 20%, they need MRI mammogram. They need to be referred to genetics because of all this family history. And also having family history of ovarian cancer, you just need one family member, you qualify for genetics. That's another thing we talk about in the other PowerPoint is the referral when someone gets referred to genetics. Let's talk about DCIS. This is usually seen as pleomorphic, linear, pleomorphic meaning different sizes and shapes, linear, segmental calcifications, suspicious for DCIS. And it's a widespread 4-centimeter area of calcifications. We typically have to bracket it, and that sometimes you have to use 2 wires for that to remove that entire area. Whenever someone has a biopsy and you're still worried about cancer, it's called discordance. They need to be excised. That needs to be excised. So they need to go to surgery. If they're concordant, they need a short-term follow-up. And there could be a question on score where if it's a suspicious mass and the biopsy is benign, you want to treat it as discordant and you have to take them to surgery. All right, let's go back to DCIS. It's non-invasive. It's inside the ducts. These are the atypical cells inside the duct, more than half the duct now. That's what differentiates a DCIS with ADH. ADH is less than half the duct. So treatment options, you could do a lumpectomy or partial mastectomy plus or minus radiation. Most of the time they need radiation. Mastectomy if they're extensive DCIS, and if you're doing a mastectomy, they need a sentinel node. If they're hormone receptor positive, they need tamoxifen or aromatase inhibitor. If they're high-grade DCIS and have only 1 millimeter margin, we really need about 2 millimeter margins for DCIS. And if they have recurrence on that side with a prior history of lumpectomy radiation, they now need mastectomy along with sentinel node. You always want to consider sentinel node with mastectomy for DCIS because you want to make sure that there is no, just in case there is invasive cancer, the risk of cancer going to the lymph nodes is higher, is why you're doing a sentinel node. Invasive breast cancer invasive ductal is the most common, followed by lobular. Lobular typically tend to be multifocal, multicentric, bilateral. It's usually pathologists will call it E-cadherin negative. I think of E-cadherin as a glue that can clump all the cells together. When you don't have the glue, the cells are form a single line pattern. And that's why these are sneaky cancers. They don't, they're not seen very clearly on a mammogram. And that's why we also need an MRI in addition to a mammogram. And that's why sometimes it's hard to see them in the lymph nodes too on imaging until you go to surgery. So that's a take-home message on that. There's other types of cancers, mucinous, generally favorable prognosis. If you hear the word metaplastic, typically these are pretty aggressive cancers. They are triple negative and chemo-resistant. Let's talk a little bit about staging. So there's TNM, tumor nodal size metastasis. There's the AJCC 8th edition, which incorporates the hormone receptors, so estrogen, progesterone, HER2/neu, grade, also multi-gene assays. This is all in your Sabiston. And also Oncotype DX is incorporated into the AJCC 8th staging. And so the same anatomic TNM can have different stages depending on the hormone receptor status and the oncotype status. So let's look at these practical examples. If it's a small, no negative hormone receptor positive, HER2 receptor negative tumor is a low-grade tumor, favorable stage, usually early stage, stage 1. Same size, but it's ER/PR negative, HER2 positive, or triple negative. They all have higher prognostic stage. And node positive, ER positive, HER2 negative tumor with low oncotype still can have better stage than a triple negative, but node negative. So the concept matters more than memorizing every table. The hormone positive, HER2/neu negative, low grade, better stage prognosis. Triple negative, HER2/neu positive, high grade, worst stage, worst prognosis. So that's important to know. So let's talk about systemic therapy. For early stage cancer, node negative, hormone receptor positive, or limited node positive, typically we go to surgery first. Whether it's lumpectomy, mastectomy, they need sentinel node, they need endocrine therapy, pretty much for all ER positive tumors. The chemo decision really is guided by the size and the grade and the assay, whether it's Oncotype or MammaPrint. We don't usually get MammaPrint. That's another genomic assay that we don't do at Ohio Health, but other places do. And it's important to know when you get Oncotype and what size of tumors. And do you get it on premenopausal, postmenopausal, lymph node positive, lymph node negative? So I did talk about TAILORx, RxPonder. Without confusing you, going into too much detail, we will ask you questions on these two trials when you're on the service. So you want to look up Oncotype, also TAILORx and RxPonder. For premenopausal women, we typically give tamoxifen, or we do ovarian suppression with like Zoladex injections, and they get aromatase inhibitor. If they have high-risk cancer, for postmenopausal women, they typically usually 3 different options of aromatase inhibitors: and anastrozole, letrozole, exemestane, or tamoxifen. They can still get tamoxifen if they don't tolerate AIs. The teaching point here is hormone receptor positive, HER2 receptor negative. Endocrine therapy is the backbone. Chemo is added based on staging biomarkers, and it's not given to everyone. That was very different than when I was in training. Let's talk about HER2 positive tumors. These are small tumors, should go to surgery first. Less than 2 centimeters should go to surgery first. They usually get paclitaxel with trastuzumab or Herceptin for 1 year. We want to de-escalate the chemo regimen for these patients because it's less than 2. But if they're more than 2 centimeters or have a lymph node positive disease, they really need neoadjuvant chemo with immunotherapy. So usually chemotherapy, TCHB, Taxotere, Cytoxan, Herceptin, Perjeta, and they have surgery. Then they continue the trastuzumab, pertuzumab, assuming they got good PAT-CR. If they still have residual disease, they get Kadcyla. That's based on Catherine trial, which you don't need to know probably for the rotation, but also known as TDM1. Kadcyla, also known as TDM1, for the residual disease if they're HER2 positive. Endocrine therapy is always added when they're hormone receptor positive. So the idea here is if you're HER2 positive, chemo plus trastuzumab. Trastuzumab is immunotherapy, it's not chemo, but you need the trastuzumab to make sure the chemo enters the cell and kills the cell. If there is no trastuzumab, the chemo is not going to work. And neoadjuvant is favored in T2 or node positive disease, and you want to assess the response. They're triple negative cancers. Early cancers, triple negative, can go to surgery, then they get chemo in the adjuvant setting. But same as HER2 positive cancers, if they're node positive or stage 2, they usually get 2 centimeters or node positive, they typically need neoadjuvant. Now we talk about this Keynote, which is where they get Keytruda, and that they really is good survival benefit. If there is residual disease, in addition to the Keytruda, they get capecitabine, and that's all Keynote 522. If someone has metastatic disease or stage 4, it depends on what type of metastatic disease. Is it hormone receptor positive, HER2 receptor negative? Those guys get endocrine therapy, CDK4/6 inhibitors. If it's metastatic HER2 positive, they get chemo, also trastuzumab. They're on trastuzumab and pertuzumab forever. If they're triple negative metastatic, then they get chemoimmunotherapy, depending on the biomarkers. So what is the take-home message? Early triple negative, they usually get chemo after surgery. If it's bigger, T2 or node positive, get neoadjuvant. Metastatic ER positive, get endocrine-based. If they're metastatic HER2 positive, they get immunotherapy-based. The other thing I was going to say is stage 4 disease, surgery is we only recommend surgery if there's bleeding, infection, or pain. There's no survival benefit with surgery. I keep wanting to operate on these patients, but we're not able to find. We go through a lot of these studies for our fellow journal clubs and reviewing articles. There is no survival benefit in these patients. So lumpectomy with whole breast radiation is same survival as a mastectomy. So it's really shared decision making. You want to tell patients, show them the images and show how big the tumor is, so on and so forth. There's absolute relative contraindications. If there's prior mantle radiation, multicentric disease, persistently positive margins, pregnancy needing radiation, then they need mastectomy. Of course, patient's preference, genetics, reconstruction, all of that. Sentinel node. Z11 keeps coming up. It's now an old study, over 10 years now. So these are the patients that are 1 to 2 positive lymph nodes, non-palpable. If you go to surgery, they are getting lumpectomy. You can omit axillary lymph node dissection. The same study was seen, another study called AMAROS, but this study included a mastectomy patients up to 17%. It's the very same thing. You can omit axillary lymph node dissection if it's less than 2 lymph nodes. If they're more than 2 lymph nodes, they need axillary lymph node dissection along with radiation. So basically, the lymph node dissection is reserved for heavy nodal burden. Matted nodes or sentinel nodes is not feasible. So take-home message, small tumors, 2 positive lymph nodes, lumpectomy. If they're getting radiation, no need for other axillary lymph nodal surgery. Things to know for boards, long thoracic innervates serratus anterior, and that can cause wing scapula. Then thoracodorsal nerve, which innervates latissimus dorsi, and the swimming motion, the abduction, the adduction, that type of motion is inhibited. Intercostal brachial cutaneous, that's a sensation. It's hard to preserve these sometimes. If the tumor is inside the nerves, then that's medial pectoral, usually pectoral major and minor muscles. Inflammatory breast cancer, usually if it's more than 1/3 of the breast and there's poterange, you may not feel a mass. You just see inflammation, redness. That's usually inflammatory. It's a clinical diagnosis. They need neoadjuvant chemo, followed by modified radical mastectomy or mastectomy with lymph node dissection, then radiation afterwards, post-mastectomy radiation. Systemic therapy overview, if the hormone receptor positive, they need endocrine therapy. Chemo depends on stage and genomics. I think we've already went through this. If it's HER2 positive, if it's a smaller than 2 centimeter tumor, they need surgery first. If it's more than 2 centimeters, they need neoadjuvant. But somehow they always need the Herceptin or the trastuzumab. Triple negative chemo is the primary systemic therapy, often neoadjuvant, if they're more than 2 centimeters or lymph node positive. Radiation therapy, usually given after lumpectomies. I said whole breast radiation. They can also get hypofractionated, short course radiation. There's some nuances with that. But for you guys, just for the boards, post-mastectomy radiation, typically larger tumor, many lymph nodes. It improves improves local control and some survival in some cases. Role of breast reconstruction, it improves psychosocial quality of life outcomes versus mastectomy alone. does not worsen oncologic outcomes or delay adjuvant therapy when planned appropriately. That's important. And the different options are oncoplastic breast conservation, implant-based, autologous, or combination. The oncoplastic techniques, you can do reduction, you can do mastopexies. If you're with us, we do Goldilocks mastectomies, and you've seen the wise pattern incision that we use for that. There's also regional flaps that plastic surgeons will use sometimes to cover up the area, the deformity in the chest wall. It definitely requires close coordination with radiation, and you always want to put clips in the cavity so the radiation oncologist knows exactly where to go. Reconstruction after mastectomy could be with implants, expanders. You started with expanders, you put saline in it, expand it, then you change it out for permanent implants. There's autologous, which is the tram and the deep, the LD, the gluteal. There's the tug and the PAP. There's a combination with LD and the implant. Choices really depend on skin envelope. I really haven't seen too many of these other than the deep and the LD, but it depends on a number of different things. Implant-based reconstruction is really good for small-breasted women. Shorter operation, no donor side morbidity, easier. Relative contraindications if they're large tautic breasts, but anymore we can perform this for many people. The bigger contraindication is really smoking, obesity, BMI of over 38. They really don't want to do any type of reconstruction. That's why I brought back the Goldilocks into town, because we have a lot of patients who are over BMI of 38. So they needed some sort of reconstruction, and the Goldilocks has, turned out to be a good option. Timing of reconstruction, if it happens the same day, it's called immediate reconstruction, where you do the mastectomy, they get the reconstruction. Delayed is where they have the mastectomy now, flat closure, come back after their oncologic treatment. Usually they start with an expander, then implant or flap. Delayed immediate is this concept where knowing that they need a flap down the road, they place an expander at mastectomy and decide final method after radiation is completed. If the implant is subpectoral, meaning underneath the pec, and the muscle covers it partially, that's called subpectoral. Prepectoral is the most common. People really don't do subpectoral. It's barbaric. It's painful. The prepectoral is lays on top of the muscle, doesn't have as much pain. The prepectoral pros are less pain, no animation deformity. The cons are higher surgical site infection, especially in the radiated fields. Subpectoral may be preferred in higher infection risks or thin flaps. But some of the complications from implant-based reconstruction include capsular contracture, malpositioning, seromas, infection, flap necrosis. Also, risk is increased with radiation, smoking, obesity, large breasts. Radiation to expanders is worse than permanent implants. Autologous is best after radiation. There's the pedicle tram based on the superior epigastric. There's deep based on deep inferior epigastric. It all has its good and bad. There is the SIA, which is a superficial inferior epigastric vessels. There's latissimus dorsi. There's the TUG, which is a transverse upper gracilis. PAP is the profunda artery perforator flap. And there's a gluteal base, the S gap, I gap. You just need to know this for the exam purposes. We really don't see a whole lot. But if they've had abdominoplasty, they really cannot have any of these surgeries because that is violated. If they had prior radiation, they had higher complications. Radiation after completed implant reconstruction is better than radiation to expanders, but still higher capsular contraction. Radiation after autologous flap, mainly more fat necrosis, overall acceptable outcomes. And remember, if a woman has breast cancer in one side, she can have symmetry procedure on the other. This is based on the Women's Health Care Rights Act of 1998, which mandates coverage for the other breast for symmetry purposes, whether it's surgery, prosthesis, or lymphedema. And usually people contralaterally, they either get reduction, mastopexy, augmentation. And it's important to know what patient wants, what their vision is for their breast and what they want. Nipple areolar reconstruction is performed after mound shape and size is finalized. Number of different ways to do it. They can use local flaps, grafts, allogenic matrix, or sometimes just tattooing. We don't really get involved in this aspect. This usually is done by the plastic surgeons down the road. Some complications are loss of projection, partial flap loss, or color loss. And in plastic surgery world, they revise these patients so many times. They have surgeries after when the tissue expanders come out and implants are placed. They get fat grafting, skull revisions, capsulotomy, all that stuff. For the autologous flaps, more early revisions, more early revisions. But then for the autologous flaps, they get revisions early on. For the implants, they have more late revisions. There is this BreastQ that actually talks about how the autologous flaps, they have more higher satisfaction, specifically the deep. I went through that really quickly. Hope that makes sense. You guys are welcome to call me, email me with questions. This is sort of just an introduction so that you have an idea before you come to the breast surgery rotation. It is complicated. It's not as easy as you think. And that's all I have for now. Thank you for listening and thank you for watching. I look forward to having you on the rotation. Can't wait. Bye-bye.